Welcome, everyone, and thank you for joining us. My name is Molly Felton, and I'm the Senior Specialist of Online Learning here at APIC. The Association for Professionals in Infection Control and Epidemiology is pleased to present this webinar as a partnership with the National Emerging Special Pathogens Training and Education Center, otherwise known as NETEC. Today's session is titled Discussion on Special Pathogen Preparedness, Revised IC Joint Commission Standards. And now it is my pleasure to introduce our first speaker for today's webinar. Angela Vasa is the Director of Biopreparedness and Special Pathogen Programs at Nebraska Medicine. She serves as the Director of Consulting Services and Metrics Development at NETEC and is the Program Director for the Region 7 Regional Emerging Special Pathogen Treatment Center. Angela is also a scholar in the Global Center for Health Security at the University of Nebraska Medical Center. She joined the Nebraska Bio-Containment unit team in 2009 and continues to be an active clinical member while serving as the program director. Angie, welcome to the program. The audience is yours.
Great. Thank you, Molly, and good afternoon, everyone. I'm excited today to introduce an overview of our National Emerging Special Pathogens Training and Education Center and to partner with my esteemed colleagues to overview the Special Pathogen Preparedness approach to the revised Infection Control Joint Commission standards. These standards went into effect July 1st of 2024, so they're already active, and we're excited to partner with you to provide a little bit more information on how to implement them. Next slide. So our webinar will provide an overview of the National Special Pathogen System as well as NETEC, the Joint Commission pre-publication standards, and the now active standards that went into effect on July 1st. But we will not be discussing in detail any of the other accrediting bodies, including the DNV Healthcare, Accreditation Commission for Healthcare, or the CIHQ, Center for Improvement of Healthcare Quality. Next slide. And so as we go through the agenda, just a breakdown of the 4 sections that we're going to cover. So starting out with an introduction, then we'll go through the discussion of changes to the elements of performance, including a focused review of IC 07.01.01. We'll move into a more detailed discussion of environmental infection control, including the cleaning, disinfection, and waste management processes. And we'll close with a discussion of education, development, delivery, assessment, and resources that are available through NETEC. Next slide. So NETEC and the NSPS leadership is comprised of a consortium of members from the University of Nebraska Medical Center, Emory University Hospital in Atlanta, and Bellevue Hospital, part of New York City Health and Hospital Systems in New York. NETEC was formed back in 2015 as a following the 2014-16 West Africa Ebola outbreak, where all 3 of our organizations provided care for patients with Ebola virus disease without any transmission to staff or community members. NETEC today sets the gold standard for special pathogen preparedness and response across the health systems in the United States. And we're working to develop the National Special Pathogen System, which will transform healthcare readiness by expanding our foundational services and building out a national system of care. Next slide. We do this in a variety of ways, and we have 4 different pillars, which we'll get into a little bit more in depth. But our products, services, and resources really span the spectrum of consultation and assessment, where we help healthcare facilities and EMS agencies prepare for special pathogen events. We follow that up with resources, education, and training for all types of healthcare professionals and public health partners. We have the Special Pathogens Research Network, which really works to provide researchers with training tools and resources and to strengthen an infrastructure for rapid response research in the face of a special pathogen event. And lastly, we have international partnerships and programs, which we established to organize, plan, and advance strategic collaborations to improve our preparedness response domestically and in the global high-level isolation unit capacity. Next slide. And so as we said, we have 4 areas of focus, and some of the key things that we want to share around how you can leverage these activities are to be able to use our self-assessment tools, virtual consultation, and on-site assessments, which are all free of charge to requesting organizations. to access our education and training tools via the website, which are online modules, a repository of resources, exercise guidance, and then updates on any in-person or virtual courses that we're hosting. And you can also access our research network through some of the policies, procedures, and data capture tools, as well as requesting personalized assistance through our Ask an Expert portal. Next slide. So NETEC is partnered in partnership with the regional emerging special pathogens treatment centers, which we are calling our current level 1 facilities. There are 13 regional emerging special pathogen treatment centers, or what we call RESPECTs, and they are in each of the 10 health and human services regions, with 2 in 3 of the different regions. So there are 2 in region 5, as you can see here on the map. There are 2 in region 4, and there are 2 in region 3. These level 1 facilities are really responsible for maintaining the highest level of preparedness and response to receive patients suspected or confirmed to have a special pathogen, and to provide outreach, education, and resources to their regions and surrounding areas, advancing readiness not just in their own organization, but in their other organizations that they partner with. Next slide, please. You can go forward. So the National Special Pathogen System, you might not have heard of the NSPS, and so we want to really say a little bit more about what the NSPS is. This is really a re-envisioning of a tiered system of care with 4 facility levels, levels 1, 2, 3, and 4, to increase capabilities to care for suspected or confirmed patients with high consequence infectious diseases. NETEC serves as the coordinating body for the NSPS as directed by Congress, and is working closely with those 13 regional treatment centers to identify the required capabilities, capacities, and functions that these levels of facilities will provide to the United States. Next slide, please. So NSPS mission is complementary and in partnership with NETEC, but it's more specifically focused on healthcare and patient outcomes. So our mission is to develop a coordinated network of high-quality special pathogen care dedicated to protecting our patients, communities, and the healthcare workforce, with a vision to save lives and protecting our workforce through agile and comprehensive system of care. We'll know that we've achieved this in our aspiration goals when we see 0 preventable deaths after special pathogen infection. We're able to mobilize this network within 2 hours of an identified event, and that 100% of people across the United States have equitable access to high-quality special pathogen care. And this includes all 10 HHS regions and the US population. Next slide, please. So the NSPS evolved. So if you were working in healthcare back in 2014 and 15 and through the last decade, you may have been familiar with the tiered system that was stood up through ASPR and CDC, with assessment centers, treatment centers, and regional centers. In 2020, this was reestablished and re-strategized to re-envision the way that the National Special Pathogen System could expand from Ebola to include all special pathogens, and to really develop a more coordinated system and strategic response for a sustainable tiered approach to special pathogen care. So as we said, NETEC is leading the NSPS strategy implementation, which includes the development of the minimum capabilities for each level and providing coordinated support. If you go to the next slide, the reason that this is critical and why we opened up the webinar with this is that every hospital in the US is envisioned to be a part of the NSPS, whether you are recognizing that or not. And this is particularly true for the level 4, which is really any healthcare institution where a patient might present seeking care. And what we're asking of those level 4s is that they're able to provide short-term safe care or coordinate rapid patient transfer to a level 1 or 2 facility, focusing on the Joint Commission requirements, which we'll explain in more detail, to be able to quickly identify, isolate, and notify the appropriate providers of a potential suspected case. Level 2 would be able to provide highly specialized care for special pathogen patients for the duration of their illness, up to and including critical care. And the level 1s, the existing regional treatment centers, provide all of that specialized care, and in addition, provide regional coordination, outreach, resource development, and highly specialized care. Next slide. And so now I'm going to turn it over to Carrie Love to provide an overview of the changes to the elements of performance with a focused review of IC 7.01.01, addressing the identify, isolate, and inform concepts for high consequence infectious diseases. Carrie has worked in healthcare for over 30 years as a registered nurse and discovered her passion for infection prevention and epidemiology 20 years ago. She joined Emory Healthcare in April of 2019 as the Corporate Director of Infection Prevention and is certified in infection prevention and control, has been recognized as a Fellow of APIC, and is currently completing her dissertation as a PhD candidate in the Translational Health Sciences at George Washington University. Carrie, I'll turn it over to you.
Thank you, Angela. Good afternoon, everyone. We can go ahead and go to the next slide. So in discussing the standard, the new standard, this term high consequence infectious disease has come forward, or special pathogen. And while there's no standardized definition for this, there is an expert consensus group that has defined what a novel or reemerging infection is. So it's got to be something that's easily transmitted from person to person. There are limited or no medical countermeasures. So no vaccine, no prophylaxis, high mortality, which requires prompt identification, implementation of infection control activities, so isolation, and having the appropriate PPE for the people who are taking care of that patient, and then rapid notification of public health. So identify, isolate, inform. You're going to hear that multiple times through here, and that's what we're going to be focusing on. So as an example, a high consequence infectious disease or a special pathogen would be MERS, or a novel influenza. Ebola, obviously, is the one that everybody tends to think of. Now, this is going to change over time. It's going to reflect what's happening on a regional or a global level. And we've got folks who are fortunately keeping an eye on these and keeping us alerted to the potential. I mean, that's one of the roles that NETEC does. So let's move to the next slide. So why did Joint Commission update the standards? So an overarching goal was to condense and reorganize the infection prevention chapter. Those of you who've been doing this for a while know that we've had multiple standards and elements of performance that we've had to meet for the past several years. They've simplified it, and there are 4 standards and 14 elements of performance. So they're trying to continue, they're continuing to simplify the requirements so that there's more meaningful evaluation, and that they're not just coming in and checking a box and saying, you did this, you did that, you didn't do this, you didn't do that. So things that actually impact the day-to-day operations of a hospital. And this is the good piece, is trying to align more with the CMS conditions of participation. So it's all in good intent. And I think that as we start to discuss this ICO 7010101, you'll see some of the benefits there. So next slide, please. So here's the standard. The hospital implements processes to support preparedness for high consequence infectious diseases or special pathogens. So what we were just talking about. They released this in December of 2023. It went into effect July 1st of 2024. So this is a new standard for surveyors, but they are surveying to this new standard. So the complete rationale behind it is it speaks to a lot of what Angela was talking about, is that we need to make sure our hospitals are prepared. There aren't currently, mandatory requirements for hospitals to implement training or competency assessment on special pathogens. So this was an opportunity to make sure, should we have another COVID pandemic, or should someone present somewhere with a special pathogen, that hospital can at least identify, isolate, inform, and make sure that they can care for that patient until we can get them to another appropriate care center. So, it's a standardized way to develop preparedness. And we're going to be talking about the hierarchy of controls. We're going to be talking about basic infection control protocols and processes that we all do every day. It's just that we need to be aware and apply them to these special situations as well. Next slide, please. So identify, isolate, inform. We're going to go through that. Next slide. Yes. So as part of this element of performance 1, develops and implements protocols for high consequence infectious diseases. So these protocols need to be available for use at the point of care. When we're thinking about this, you have different places where your patients can present. They can present in the ED. They can present in a clinic. So identifying some process of screening patients at the entry point of the hospital. We're looking for respiratory symptoms, fever, rash, travel history. So does this patient have symptoms that would trigger, oh, gee, maybe we better get this person, maybe we need to put a mask on them. And then appropriately isolating them, informing public health, performing other people in your organization who need to know and understand. And then putting those procedures in place, the hierarchy of controls, so isolation, disinfecting, making sure that we've got negative air pressure if needed. And then what to do with the waste, how to clean and disinfect, and the equipment. Next slide, please. So the elephant in the room. So the second element of performance is that a hospital develops and implements education and training and assesses competencies for the staff who will implement protocols for high consequence infectious diseases. And we're going to have some more conversation about that later. Carrie Billman is going to give us some more information. But ultimately, hospitals have the flexibility to define the competencies required by the organization. It could be associated with the practical application of identify, isolate, inform. Having someone take a test and having that as documentation that they understand what it is. A measurable method of demonstrating the accurate completion of a procedure or a process. The organization actually decides what that's going to be. So we'll discuss that later. Next slide. So to jump in a little more, when we identify, we're recognizing signs and symptoms, epidemiological risks that indicate a high consequence infectious disease, travel history, where they traveled, knowing what travel alerts are out there for folks. Promptly identifying and effectively isolating the individual. Sometimes we have folks who just go through the motions of asking questions and don't really take the time to say, yeah, okay, yeah, you've got a fever. But knowing what to do in that case, giving the patient a mask and notifying someone that we need to do something. And then having some sort of algorithm so that you can notify infection prevention, next steps, public health, who's the appropriate person to reach out to, infectious disease, those types of things should be planned ahead of time so that you're not scrambling to figure out those pieces then. Next slide. So identify, this is an element of performance. So have a procedure for screening at the points of entry. I talked about this, but you at minimum need to screen for respiratory symptoms, fever, rash, and travel history. This could be your EMS team, your emergency departments. It could be registration in the emergency department, urgent care, and even ambulatory clinics. So if you have, urgent care, ambulatory clinics, you need to also think about what they will do should they identify someone. We all think about the ED, but think about who in the ED is that first point of contact for that patient. The sooner we can catch this, the better. And having signage that directs a patient if they have symptoms to wear a mask, etc. So that's part of the identified element of performance, having a process in place. Next slide, please. So if they have positive symptoms and a positive travel screen, what are you going to do? So you need to know what those steps are. Are you going to put a mask on them and put them back in the waiting room? Probably not. If you're going to put them in a special room until you can open up another room for them. That's what you need to decide now and figure out where that person's going to be. What PPE do you have available at that point of care right then, so that the staff can wear what they need to wear, and that you can get the patient, if they're having vomiting, you can get them an emesis bag, the PPE they need to wear, and then who needs to be informed, and then what to do next. So where will the patient go? Do they have an exam room or a treatment room? And what if they have family members with them? What are you going to do with those family members? Those are things that you need to think through and act out as part of an exercise to meet this element. Next slide, please. So isolate. This is something we do in the hospital every day. So we isolate patients who have transmission or organisms that can be transmitted. So know what PPE and the donning and doffing techniques of that PPE. Make sure your staff is comfortable in doing it appropriately. And as we said earlier, you have to have it at the point of care, anywhere the patient is being cared for. And then again, plan ahead. Where will they go? Know what you're going to be doing with that patient. Are you going to have to take them outside to get them to another place that's away from everybody else? So understand those procedures above and beyond what we do today for C. diff and Candida auris and those types of things. Next slide. So think about, so once you've designated your room, what kind of equipment is going to be in that room that you need and what can be removed. These two photos here show, I wish we all had this, essentially a garage door that you can pull down over all the supplies and keep them protected. But you need to decide what you absolutely need in there and remove everything else. Make sure your hand hygiene stations are full. Commode or private bathroom. Additional waste bins. You are going to generate a lot of waste, and you're going to be able or need to be able to hold it, especially if it's a category A. Isolation signs and a log sheet to keep a log of the personnel who are actually going in and out of the room. Now, you don't want everybody and their friends going in. You want to try to limit that, but you do need to monitor those patient or those staff members who are going in. So if you can at least prepare and have a checklist beforehand, that's going to help you quite a bit in having walked through this and knowing what you're going to need and what you can pull out. Next slide, please. So, if the patient can walk, you're going to want to make sure that the route that you're taking that patient to get them to their room is free and clear of other folks. You might have to ask other patients and staff and families to vacate the route. The patient is going to be needed to be either in a wheelchair or have what they need to, let's see. So in case they have fluids coming from any of their orifices, you're going to want to make sure that you've got them wrapped in something or have something that you can utilize to help contain that. And then once the patient gets to the room, help them understand why they're there, what the expectations are, and that they have to remain in that room. So it's always a good idea to practice this and figure out what the best way is to go. The shortest route might not be the best route. Next slide, please. So informing. Most folks have a call tree of some sort for emergencies. What I would recommend is outlining, who you need to contact in this case. So you're going to need to talk to public health. You're going to have key hospital staff that you're going to be contacting. Your local law and regulation requirements are going to differ between states occasionally, so know what those are. You might, stand up an incident command center, your emergency management procedure. So hopefully your emergency operations plan has this information in it. So if it doesn't, this is a great opportunity to bring that to that team and talk through who's going to call who, What should their actions be? And don't leave this till the last minute, because you'll end up with a game of telephone and multiple messages getting spread. And you're going to want to make sure you get the right information to the right person at the right time. So next slide, please. So procedures to control this are, obviously isolation. We want to reduce exposure. We want to reduce exposure among staff, patients, visitors, and utilizing that hierarchy of control, which Pam's going to talk to you a little bit more about here in a little bit. You also need to understand and develop procedures for waste management, cleaning, and disinfection of these patient care spaces. Where they came in, if they were sitting in the waiting room, how did that patient get to the hospital? Did they come via Uber? Did a family member drive them? So thinking through all of those things are important pieces whenever you've got a patient that presents with potential symptoms. So next slide, please. So NIOSH has this lovely graphic of the hierarchy of controls. And you see at the bottom, the least effective is PPE. That's how we protect our workers. The preferred order, obviously, is to never be exposed. And, as you work down, there are isolation controls or engineering controls that we can use, isolating people from the hazard. That's moving that patient to another room. Substituting these things can control the exposure without significant human interaction. So those are preferred, but we also realize that in some cases, we've got to have our staff take care of the patient. So PPE is what's going to protect that worker. Next slide, please. So this is just a sample list. You can get this on the CDC website. So this is talking about the type of PPE that you would want to use if caring for a patient with viral hemorrhagic fever. So this is an example of a list that your organization may want to create a checklist off of this, so that when you have a staff member putting on the PPE donning, you have an observer who is using that checklist and say, okay, do this next, do this next. You want to do the same thing for doffing, for removing the PPE, because that's where folks contaminate themselves, is during the doffing of the PPE. So make sure you've got something in place, a checklist on what to put on when and how to safely remove it. Next slide, please. And then cleaning and disinfection, you're going to want to make sure you've got EPA approved lists or disinfectants. They're on the list. Infection prevention, we're the ones who'll advise. We'll help you figure out if what we have works or if we need to bring in something else. And then again, I want to emphasize limiting the number of personnel entering the care space might require nursing to perform some initial cleaning and disinfection. So, that's something that you can practice while they're in PPE if you're doing the drill, so that they understand what they need to do at that time. And then again, the waste, if they have viral hemorrhagic fever, should be sequestered until we actually know what it is. And if that infection is confirmed, the waste is going to be classified as a Category A hazardous substance. And the next few slides, I know Pam's going to talk a little bit about this, so we want to move into the next section. I am honored to introduce Pam Ferrara-Rilmore. Pamela completed a Bachelor of Science degree in Medical Technology at the University of Maryland at Baltimore. She is a certified American Society of Clinical Pathologists, as well as certified in infection control. She's worked as a microbiology lead technologist in a 900-bed hospital for 10 years, served in a leadership role for a private laboratory for 7 years. And we are so lucky that she returned to the hospital setting in 2007, trained as an infection control practitioner, and now serves as the Director of Infection Control and Prevention and lead infection preventionist consultant for the Bio-Containment Unit at MedStar Washington Hospital Center in Washington, D.C. Thank you, Pam.
Thank you, Carrie. I thank you so much for that wonderful introduction. I'm so grateful to be sharing this information with this group today. Next slide, please. So Carrie already touched on this topic on her previous slide, and I'll be reinforcing the principles of waste management, cleaning, and disinfection in this segment. The Joint Commission describes in detail the requirement for waste management and cleaning and disinfection in the standard IC 07.01.01 EP1. They address pressure relationships, air exchange rates, filtration, temperature, and humidity. I recommend consulting with your facilities team or environmental safety team for specifics on these parameters. In addition, because capabilities for assessing, testing, and treating patients with high consequence infectious diseases or special pathogens differ across hospitals, the expectation is that hospitals will work closely with their local public health authorities to determine next steps, including the need for patient transport for a higher level of care. Here's an analogy for all my baseball fans. I think of this component like a baseball game at a ballpark. Cleaning and disinfection is like when the hitter hits the ball right down the baseline and it lands into the player's mitt. Waste management, on the other hand, can be a bit tricky. You may feel like maneuvering the regulations of local, state, and federal government are like a fly ball and the outfielder misses it, and at the moment it feels like chaos is going on. It may take more than one player to get the ball back to the home plate, but with teamwork, it can be done. Next slide, please. Let's go into some detail. It's important to remember that waste management is dependent on the infectious agent. Most infectious diseases we encounter are classified as Category B regulated medical waste, but what we're going to talk about today is Category A waste. Category A waste is defined as causing disability or life-threatening or fatal disease in otherwise healthy people. And that's why it's so critical that we coordinate with regulatory agencies and follow the guidance that I'm about to review. Always package and transport in compliance with hazardous materials regulations. Have plans to address the entire waste life cycle from initial generation to the final disposition. Category A waste must physically be separated from other solid waste at the point of origin. The safest and best option is treating Category A waste so that it is no longer infectious. It's a process known as inactivation, where the waste is generated. For example, autoclaves use saturated steam under pressure to heat materials to a high enough temperature for a long enough period of time to inactivate the pathogens of concern. If you don't have inactivation capabilities, or when in doubt, sequester the waste and coordinate with your local public health authorities. It's important to wrangle the troops by engaging emergency management, life safety, environmental services, your executive team, and frontline staff. Next slide, please. Have a plan and conduct practice drills. I can't say that enough. Practice, practice, practice. Practice makes perfect. Identify a sequester location. Identify the route for relocating the waste, and then use checklists to ensure all essential steps are followed. Ensure the waste handlers are trained to don and doff personal protective equipment to minimize self-contamination. Next slide, please. Just as a reminder, just as important as waste management, we must consider cleaning and disinfection. Refer to the EPA register to determine the appropriate disinfectant for the infectious agent. Disposable equipment options are always preferred. For reusable patient equipment, follow manufacturer's instructions for use. For high-touch surfaces, follow disinfectant contact times and wear appropriate PPE during cleaning and disinfection. Next slide, please. To reiterate, I want to review again that disposables are always preferred and always follow manufacturer's instructions for use, and always remember you're not alone. So when in doubt, coordinate with your local public health authorities or NETEC for guidance. Next slide, please. Listed on this slide are resources for waste management specific to high consequence infectious disease. This actually concludes my portion of this presentation. I would like to thank you, and I would also like to introduce our next presenter, Carrie Billman. Carrie Billman will be discussing education and training. Carrie is the Director of Education and Infection Prevention for the Johns Hopkins Special Pathogen Center, Bio-Containment Unit, and a Senior Infection Control Epidemiologist for the Department of Hospital Epidemiology and Infection Control at the Johns Hopkins Health System. In her role, Carrie leads infection prevention and external education activities for the Johns Hopkins Bio-Containment Unit, including training and education for trained observers and BCU clinical staff, policy and protocol development, and serves as lead infection preventionist during BCU activations. Carrie?
Thank you so much, Pam. I really appreciate the introduction and being able to speak with everyone today. So I'm kind of doing the wrap up, right? We've talked a lot about what the new expectations are, and now we have to figure out how are we going to develop and implement this education. Next slide, please. So a little bit more about what a high consequence pathogen is. I've seen a few questions come through in the Q&A, and just kind of maybe delving a little bit more into what that looks like at each facility, some education, different ideas and types, what might work for you or your health system, and really what does competency mean. Next slide, please. So I know there was a slide previously from Carrie about what a high consequence pathogen is. It's something with that higher morbidity, mortality, and no active medical countermeasures. So I think really what I wanted to touch on here that hasn't been is, or more so expand upon it, is that this does change with time. So one of the things listed was a novel respiratory virus. So we just lived through a pandemic. Obviously, that's going to change. The next one might be different. It might be in a year. It might be in 20 years. We don't know what to expect. The topic of Mpox, and I have it listed here as a non-high consequence pathogen, that has changed. So it routinely was considered something that would be cared for in a biocontainment unit. And then the strains mutated, they changed, and all of a sudden it was something we were seeing very frequently and kind of in every hospital setting and worldwide. And now we have more mutations coming through that are making things more virulent and could cause other problems. So really, that is going to be what's happening in the world today. What does your facility have available, and what are they considering a high consequence pathogen? Next slide, please. So staff education and caring for a patient with high consequence pathogens or high consequence diseases. So identify, isolate, and inform. It can't be said enough about how important it is to be able to educate to these things in all areas where we could potentially see a patient. So that means outpatient, that means inpatient. Who needs this education? You're definitely your frontline ED staff, anyone doing triage. Your infection preventionist should be as well-versed as anyone. And then you have to decide, should this be all staff? Depends on the size of your facility. If you're coming from a facility that has, 60,000 employees, does every single one of them need it? If you say, yes, they absolutely do, we want everyone versed in the identify, isolate, and inform, then we have to be able to prove that that education is happening. We also have to have the documentation and where is that going to live? Who's going to be the keeper of that? Of course, these new criteria are coming under the infection control umbrella, so it really should be somewhere within our infection preventionists. But we should have hospital leadership, emergency management, et cetera, involved as well. And of course, any others that you've identified. So PPE and where your patient should be placed. We talked a little bit about that. Carrie gave us some really good examples about what you need to be able to do. So you really have to be able to say, where is this patient going to be? Really, in our outpatient, our ambulatory settings, that is really what they need to be able to do. They need to be able to have a location identified where they're going to put that patient, close a door, and know who to call. Do they need the full education of exactly what PPE to wear, how to care for a patient with these different organisms? Maybe not, but they definitely need some sort of education about how to identify them and where they're going to be. We definitely want to identify what that ensemble looks like. You really want to be able to utilize PPE that is readily available in your facilities within your health systems. Trying to introduce new PPE techniques on how to don it, how to doff it, how it's going to be housed, et cetera, is really challenging. So really utilizing any PPE that would meet the CDC criteria for a full coverage for these high consequence pathogens would be preferable. So if you don't use jumpsuits for contact organisms elsewhere, they may not be the best choice to be teaching all of your staff to utilize. And we really want to also focus on what the organism of concern is and those transmission routes, right? So as infection prevention really tends to focus on how is that organism getting from place to place? Is it airborne? Is it a larger droplet, or is it a contact organism? So what is the safest way that we can keep our staff safe? Next slide, please. So what are we doing? What are people already doing? Because of course, this is already in utilization with the Joint Commission. So we're using a lot of different strategies. Is there a right one? Is there a wrong one? There might be some that become more prevalent, and it really will depend on your facility and your patient population. So some options are your My Learnings, your online modules. They are quick usually to enact. It is a way that you can prove you are reaching all staff and can be added easily into already existing annual training, annual updates, can be easily disseminated to your staff. So that can be something. Is that necessarily your best choice to get all the information out to those who would be actively caring for these patients? Maybe not, but is certainly something that would meet that criteria and check those boxes. You can focus solely on your emergency department and have education there. So because we get to kind of identify who we say are the staff most likely to be caring for these patients, you can focus your education on those identified staff, as long as you have a way to make it measurable and documented readily. So it can be difficult to hit all that staff, and we know turnover creates challenges as well as it has for all of us, certainly pre and post-pandemic. We also have visited in some facilities, some healthcare systems have created special pathogen response teams. So these are essentially super users that we're going to say we have provided education for these people. This is both maybe online, verbal, and hands-on training, certainly the PPE and the donning and the doffing practices. And they may be someone that is deployed to certain areas if a pathogen of concern is noted in a patient there. So that requires identification, likely an annual training. That should not be a one and done for those selected staff that would deploy when encountering these patients. And then, of course, if you are in an area that has a bio-containment unit or a regional treatment center, that makes it a little easier. Some of us who do have these regional treatment centers are able to say that we have identified those staff members that would work in those areas, and those are the staff members that are receiving education. Next slide, please. So talked about the ways that you can deliver this education and the frequency. So by being able to identify what a competency means to us and our facilities, that's giving us a little bit of leeway to determine how frequently we are offering this. Is this something that I am going to provide quarterly, annually, or is this a one and done upon hire? So is this something I can provide online, in person, and add to already existing education methods? So what does competency mean? So it's defined as the ability to prove knowledge and skill related to a certain topic. How can you prove that? Has to be measurable. But thankfully, they're giving us a little bit of leeway here. So they're allowing those facilities to determine what that means for them, their institution. If you are part of a health system, I think it is easier to kind of set that guideline for your entire system so that you can say, oh, system-wide, this is how we provide this education. We also, once again, have to establish who's keeper of that documentation, how it's formatted, where it lives, how can we be able to pull that information readily upon needing to prove it to a Joint Commission regulator. And then how big of a focus is this going to be on our site visits? I know that's a question. Joint Commission visits can be very stressful. Infection prevention tends to kind of be a very large umbrella encompassing lots of things that we need to be able to speak to and be able to prove that we are as up to date as the different standards tell us to be. I think there's really no set answer to that question yet. It has only been since July 1st. It's only been a month that this has been enacted. So we don't know how strict the surveyors are going to be with the guidelines until the first few waves of these site visits have been completed. It's probably will be different based on your location, on the size of your facility, and exactly, how many of these patients are you likely to see. I also anticipate that the focus of your identify, isolate, inform, your proof of competency for this education will be increased during times of any sort of active outbreak and pandemic. So if there's nothing actively going on, certainly in our area of the world that we're likely to see, I think it's going to be a box to check. I think it is going to be a much heavier focus as they identify deficiencies and as we move forward with different worldwide outbreaks and pandemic. So these are some of our resources provided, some of our EPA registered disinfectant lists from the EPA themselves. The CDC does provide guidance for what type of PPE you need. And by type, I mean what it needs to cover and kind of what level it needs to be at, but not specifics. Once again, I really encourage everyone to look through their SAP systems and what they already have present and design any sort of ensemble based on that so that you know that this is not something completely new that you're educating your staff on. So we also have our VHF preparedness checklist, excuse me, and a little bit more about our identify, isolate, and inform on the tip sheet. So we do have some NETEC support and upcoming events, developing some resources and tools for frontline facilities to improve that high consequence infectious disease programming. We are making more webinars, hopefully with the Joint Commission, hopefully again with APIC, and responding to technical service requests. We do have the PPE and Joint Commission strategies for the new Joint Commission Infection Control Standards webinar on September 24th of this year at 1 p.m. and look for that registration coming soon. So what do you need to do next? Make friends, ask questions, connect with your patient safety and your quality team for support, and get to know your IPC team and what resources you have available, both for your inpatient, your ambulatory settings. Everyone is figuring this out. We are building the ship as we are sailing it. So we want to make sure that we are trying to figure out the reconfigured standards together. We want to collaborate as much as we possibly can so that we're all presenting that united front. We do encourage you to reach out to NETEC with any questions you have in developing that, and the regional treatment center for your area. So as you saw on that map, there are lots of us and we are always happy to help. And reminder that we are moving from 51 elements of performance down to 14, but that is changed with the same content, just clarified and streamlined. So a few reports, newsletters, and listservs. We obviously recommend you get the Joint Commission e-alerts. And also Patent Healthcare Consulting does have a monthly newsletter with news from the Joint Commission and CMS. I'm not going to read all of those, but those are all the resources that are available. And we're at the point where we are going to get some questions and answers going for everyone. There have been several questions in the Q&A already, so please look at those as well for some of those answers. And I am going to go back on mute and we'll figure out where our first questions are.
Thank you, Carrie. I'm going to ask all of our speakers if they can to join us back on camera. If you do have additional questions for our speakers today, please drop them in the Q&A tab at the bottom of your screen. That is where we'll be pulling the next few questions from. And we will go ahead and get started. Let me get everyone spotlighted and we'll... All right. So this first question in our Q&A tab today, oh, and before we do start that, we have had several questions about the slides. Yes, the slides and the recording will be available within 24 hours for all attendees in your APIC online education dashboard. I've dropped that link in the chat for you as well. So let's go ahead and get started. The first one. Does your facility have any recommendations on how to cascade the concept of HCID in some key messaging for personnel that might likely encounter patients with these infections? So for example, identify, isolate plus PPE, thinking these personnel might also include primary care provider practices.
Thanks, Molly. I'll start, and then I think each of us probably have a slightly different successful strategy that has been used. I think two things that we've used successfully or heard from other facilities that have worked well is being able to leverage staff meetings. So whether that is an overarching director or a leadership meeting for all of the clinic staff or primary care providers, being able to highlight what is a high consequence infectious disease, why are we now focusing on them so much more intently? And then what does it mean when we say identify, isolate, and inform? So I think that's one strategy. The second, which nobody loves doing, but the email distribution list where you can send a situational report highlighting maybe current outbreaks and why we're focusing again on the identify, isolate, and inform and some of the Joint Commission requirements are two ways to get that broader group, at least increasing awareness and engaging with them for additional information. I'm going to ask Pam, as Pam is representing MedStar Washington Hospital Center, who established their regional treatment center in the last 2 years, but previously worked as a treatment center. How have you expanded information dissemination across your teams to raise awareness of these concepts? You're on mute, Pam.
My apologies. It's a work in progress for us. We are, as we know, the standard was effective July 1. We've been reviewing the standard, trying to understand. And so we are working now with our Bio-Containment unit team, with our emergency department. That's really our first step to really kind of roll out how we can identify, isolate, and inform. So processes are already in place, especially when it comes to BCU specific task. But for the general ED, emergency department staff, that's what we're working on right now. So as a matter of fact, beginning in September, they will all go through training for personal protective equipment. And within that training, we're going to try to incorporate the identify, isolate, and inform. Again, this is a work in progress. I'm in the same boat as everyone else. Although we have the BCU, it's still a challenge. Thank you.
Thank you so much, Pam. Let's get on to another question. It looks like, does the new Ebola vaccine mean that it might be removed from the list of special pathogens? Is it effective after exposure for HCW?
I will be happy to start that answer. So we do know that the Ervebo and the Ebola vaccination practice is effective against the Zaire strain. So it was demonstrated within ring vaccination practices during the last Ebola outbreak to be effective as a prophylactic, but also post-exposure measure. So we have offered through our regional treatment centers an opportunity through the Special Pathogens Research Network to provide prophylactic vaccination for regional treatment center staff members. So that is an ongoing conversation. There's, I think, a lesser degree of information about its efficacy against Sudan Ebola virus. And so I think for the immediate future, with the ongoing high mortality, morbidity, and the transmissibility and infectiousness of 1 to 10 virions for Ebola virus, it will remain in the high consequence infectious disease category. I am hopeful that we will expand and improve our medical countermeasures so we can reduce that risk. But for now, I don't see it being moved out of that category anytime soon. I'd ask my other esteemed colleagues for any other data or information that you would offer there.
I don't think there's really a ton more to add other than, most of these viral hemorrhagic fevers, even as we are developing those medical countermeasures, they're going to maintain just that higher level of risk. So they will be unlikely to move anytime soon.
Thank you so much. I think we have time for about one more question. And I will say, if there are any questions that do go unanswered today, we will be sure to download those and send them to our speakers. And I'm sure in all their free time, they will help us answer those, and we'll post them in your APIC online education dashboard as a resource later. So let's get to one more quickly, and then we're going to have to close out. So for PPE, what is the recommended combination to prepare for multiple high consequence pathogens to simplify training?
I'll start, and once again, please feel free to join in. Kind of going back to what I had said with your PPE choices, every even regional treatment center that cares for this for a high level of patient has a completely different ensemble. It is all based on the CDC recommendations of what is necessary to care for a high consequence pathogen patient, but it is going to be a bit different. So we do treat even organisms like Ebola, for example, which we know is mostly a contact transmitted organism, as something that we also are going to provide respiratory and airborne protection on the chance that it could be aerosolized. So you are going to utilize a full coverage ensemble that is not only protecting your healthcare workers' airway, but also any points of entry that would be contact as well. And then there was a second question that kind of goes along with it about infographics for donning and doffing that you could post. It really depends on the ensemble that your facility chooses and what PPE is available. So I'll let my colleagues respond as well.
I think you answered it really well, Carrie. I think the only thing that I would add is, if you can't get everything down to one specific ensemble, at least being able to limit it to two. So, contact droplet airborne high consequence infectious pathogens like Ebola, or an airborne level that could be more applicable to the wider spread facility. In our experience, having more than 2 PPE ensembles with different donning and doffing procedures makes maintaining proficiency extremely difficult.
Thank you, Angela and Carrie. I do want to give a special thank you to Carrie, Angie, and Pam for being here today and for our partnership with NETEC. We're very excited, and as stated before, we'd love to continue this partnership. We are receiving a lot of great feedback in the chat, so please be sure to check that out. Just one final reminder that all of the resources from today, so handouts, webinar recording, evaluation, and continuing education certificate, will be available within 24 hours on your APIC online education dashboard. And then lastly, just a few APIC upcoming webinars. We do have a new series, Quality and Patient Safety for Aspiring IP Leaders, that we are continuing with tomorrow. So please join us then, as well as several other really awesome series this fall. So we will see you then. Thank you again. You may now disconnect.